What's going on, everybody? Welcome to another episode of the Core Consults RX podcast. I think this is episode 188 today.
Oof.
Inching closer
I know.
to the 200 mark.
We need a plan.
We still haven't come up with a plan, guys. We've been talking about it for 15 episodes now.
88 episodes ago, we had the famous Dr. Words
Yeah, we did.
for episode 100.
We probably just need to call him up and get him on here again because we're running out of time.
I know.
Got to book him the day of.
Well, yeah, he's busy.
He is very busy.
We need to book him ahead of time, and we do not do well with booking ahead of time.
Ever.
Do
no,
we?
No, we really don't. It's not one of our fortes here at Core Consult headquarters. Whatever we call this place. So, today's episode, a couple things. One, it is a somewhat, I don't want to say a repeat topic, but we did do this one, fall of 2021. But we're going to kind of go through it again, probably a little bit more detail, because this is a episode that is going to be ACPE accredited, thanks to our friends at freece.com. So if you are a member of their website and you're an unlimited member, so you have access to all of their content, you also get access to all of our accredited podcast episodes, and as well as future episodes. And so just like before, hopefully you guys have seen some of these before, so you kind of know the drill by now, but you will get a code, which in this particular case is going to be DMARD, D-M-A-R-D, all capital letters, to use as a password to get into the post-activity test. Pass that, and you will receive your credit. Don't pass that, and you will have to try again. And if you are not a freece.com member, and you're still listening to the podcast, get your credit. You got to join their website. They got some great content. Obviously, the podcast episodes we do with them, but then also all their monographs and live events and all kinds of fun stuff. Check that out. And there's also a discount code in our show notes, so make sure you check that out. And the link to their website to see their whole podcast catalog for the unlimited members is also going to be in the show notes. So big thanks to them for continuing to partner with us.
Yeah.
I feel like they could do so much better, but they keep throwing us a bone.
For some reason.
We love them for it. No, it's been fun. So I hope you guys are enjoying it too. But
I think this will be a good one.
I think since I already said the password to today's episode, I'm thinking you guys are at least, kind of assuming what we're going to be talking about. Some sort of a rheumatoid condition.
Yeah. Does that term pop up anywhere else?
Yeah, another rheumatoid condition.
Other rheumatoid, any rheumatoid thing.
Mm-hmm.
Yeah.
We're talking specifically arthritis.
Yes.
Rheumatoid arthritis.
R-A.
Not osteo.
No.
R-A.
And we will discuss some differences.
We just might.
So that you can tell the difference.
If you stay tuned.
They are different. So there was an updated guideline last year, 2021. Previous to that, the most recent update to the guidelines was 2015. For those of you who are familiar, there's obviously new biologic medications coming out for all sorts of disease states frequently, especially in the last 5-6 years. So even since that update in the guideline, new drugs come out. So we're going to go over everything as best we can to cover it all, but we'll start with the basics, right? Mm-hmm. So rheumatoid arthritis, different than osteo, like he said. This is a chronic progressive autoimmune disorder. Primarily affects the joints. There's definitely a complex interaction between genes and environment. So as to what the cause is, leading to a breakdown of immune tolerance and synovial inflammation, and that's what's going to affect those joints. The genome clearly plays a role in susceptibility and severity. That seems to be very clear. There's over 100 different gene polymorphisms associated with rheumatoid arthritis, and it's an autoimmune disorder.
And if you're kind of thinking along the lines of, the antigen presenting cell, the B cells or activated B cells known as plasma cells, those are kind of what are kicking off those, resulting those auto antibodies. And it's like Cole said, it's basically attacking your own bone, matrix and breaking down you're causing bone destruction. And so as far as, this condition, obviously there's lots of other rheumatoid type conditions and autoimmune type conditions. But because it is arthritis, the signs and symptoms are going to be some of them are going to be common with other forms of arthritis, such as osteo, but there's also some very stark differences. So you will get some pain and stiffness, obviously, in the joints. The stiffness in the joints is going to happen especially noticeably in the morning. And the involved joints are usually hands, wrists, feet, and there's going to be some potential tenderness, warmth, swelling in the affected joint, and there's usually symmetrical distribution. Also prolonged morning stiffness. But persistent fatigue is another kind of big red flag when it comes to the rheumatoid conditions. And then, overall, like having weak muscle tone, and then even rheumatoid nodules, which is basically like local swelling that can happen in the heart or in the lung as well. So like Cole said, we'll compare and contrast them in just a little bit, but those are some of the kind of very common and classic signs of RA.
Yeah, and I did want to mention, because I had a little history of rheumatoid arthritis.
You always do.
Because it's been around for a long time, obviously. It's been affecting people for, I don't know, I saw it in the 1500s. It was first described in the 1800s. And if you watch like an old show that was based in the 19th, 20th, early 20th century, you might hear people refer to rheumatism, which could have been referring to multiple things, like gout and things like that, because it was hard to delineate. But rheumatoid arthritis was first acknowledged by modern medicine in a dissertation by Augustine Jacob Landry Babou.
That is too many names.
It's a lot, and I don't know if I pronounced it correctly. In the year 1800, that was the first time they described rheumatoid arthritis.
How did he end up doing the differential diagnosis between that and things like gout? Did you look into that any deeper?
No,
just got his name.
Didn't dig too deep. But I did. I basically wanted to know what encompassed rheumatism, and that's where I found it.
Anything.
Yeah.
Anything they couldn't explain.
Osteoarthritis, they might have even called rheumatism if they didn't know.
Yeah. Well, they also thought it was probably a good idea to like just get some of the bad blood out of you when you were sick.
Yeah, just let it out.
Yeah, just let it on out.
Let the blood.
Let the blood.
Yeah.
We know now. It's not ideal.
Kills people.
It does, in fact, actually lower your hemoglobin.
So there are some risk factors to help us predict who might be more susceptible to rheumatoid arthritis. It usually hits between the ages of 25 to 50, but elderly patients can definitely develop it. More common in men than women, about a 3-to-1 ratio. Family history, so we talked about the genetic component is going to be a big risk factor, as well as smoking and coffee. I feel like I'm always seeing a different article about how beneficial coffee is, but a lot of the topics that we do, coffee pops up as a risk factor. What do you think that's about?
I don't know. I think it has to do with more when we're dealing with like inflammation and things like that. It's a negative aspect versus like the cardiovascular health and the wakefulness and all that kind of stuff.
That's a good point. I guess I'm mostly thinking about it with like UC and Crohn's and peptic ulcer disease and things of the GI tract or that are related to inflammatory mediators, whereas the cardiovascular stuff is where it's a
different ball game.
Whole different ball game.
Yeah, it looks like coffee is actually pretty good for you.
You don't drink coffee?
Some. I actually had coffee this morning, believe it or not, for the first time in a long time.
So like on a regular morning, what is your caffeine?
Usually a sugar-free Monster.
Yeah, okay. I don't drink coffee on a morning.
It's also my drink of choice right now.
It's
12 hours later.
It's your all-day drink.
It's really good at any hour.
No, I also do not drink coffee in the morning for my caffeine.
I do enjoy Starbucks. This is like, I know Starbucks is not real cool coffee, even though it's prices if it is such. I like some of the Starbucks coffees. I'll get those if I'm out and about.
Yeah, I'll enjoy the ones, especially the ones that taste like milkshake or good iced coffee, caramel iced coffee.
Yeah.
I mean, I can do that.
It's basically not so much coffee as it is a milkshake at that point.
Yeah, a coffee flavored milkshake.
It's cool.
I wonder what that says about us, that neither of us are daily. You know that like the most of the world is daily coffee drinkers.
Mm-hmm. We don't conform.
But we're here with a podcast.
And they don't have one.
And they don't have one.
So if you want to have a podcast, kids, don't drink. I'm just kidding. I have no problem drinking coffee. It's pretty good. I just don't like them. You know what it really is? I'm too lazy to make it.
Well, you know what it is for me? It makes my stomach not feel good in the morning. Well, because I used to not eat breakfast for years.
That might be Crohn's.
I didn't eat breakfast. And, it just didn't sit well. So I didn't drink coffee.
Shitty breakfast, Cole.
Yeah. I do now.
Oh, that's good. All right. So
Fruit Loops.
We've all grown. Fruit Loops is not breakfast. Anyways, he's a diabetes educator, folks. Eating Fruit Loops. Ugh, unbelievable. Total hypocrite. So some of the labs that are going to be important to get on a patient who you're doing an initial workup for rheumatoid arthritis, things like the rheumatoid factor assay or the RF assay. The RF test shows the presence of the RF antibody in the blood, which can be sometimes seen in people with RA, but it's only about 70% of patients who have rheumatoid arthritis actually test positive for that antibody. There's also the Anti-Citrullinated Peptide Antibody, or ACPA, which is an enzyme-linked immunosorbent assay, or ELISA, for antibodies against cyclic citrullinated peptides, or CCP. Those are going to be the most commonly used assays to attain an ACPA, and this is basically going to be helpful when we're looking at detecting early-stage arthritis. Also, some of our other inflammatory things that we typically think about, like an erythrocyte sedimentation rate. This is going to kind of show the presence of overall inflammation in the body and the activity of the disease itself. Anti-nuclear antibody, or ANA, is a very common lab that we also draw, and also kind of points to some sort of it's not specific for rheumatoid arthritis, but shows inflammation and some kind of a rheumatoid thing potentially going on. Reactive protein test, or CRP, is an acute phase protein that increases with acute inflammation. Even one lab that can be kind of overlooked a lot of times, but something that I think is still a good, easy one to get is a ferritin level. Yeah. So we typically think of looking for low ferritin if we're looking for iron deficiency anemia, but high ferritin level does indicate inflammation. And so that can be something that, also, especially when there's fatigue and you're thinking, anemia, and then all of a sudden you get a ferritin level that's really high, might want to make you recheck and see if there's anything else going on.
Think twice.
Yeah.
I coined that phrase just now.
Cole just came up with that right in front of everybody, live, only recorded.
Think we can trademark that?
No. We don't. We lack the legal.
Good.
Team.
So that's diagnosis. Things to diagnose.
Yeah.
So you would want to distinguish rheumatoid arthritis from osteoarthritis. So osteoarthritis, as far as its onset, it's not going to happen suddenly. It's insidious. It's over many years. RA is going to be gradual or sudden, so it can't happen suddenly. Sometimes weeks to months. As far as how long they're stiff, especially when they've been at rest, for instance, with osteoarthritis, they're stiff for a few minutes. It's localized but short gelling. They might describe it as a gelling after a prolonged rest. Duration of stiffness for RA, at least an hour, often longer than that, so a longer time of stiffness. It's most pronounced after rest. The type of pain, or when they have pain with osteoarthritis in motion, because they're going to have a loss of that cartilage, it might be bone on bone, so on motion they're going to have pain with prolonged activity, and it's relieved when they're resting. With rheumatoid arthritis, even at rest, they can have pain. It might even disturb their sleep. As far as fatigue, might kind of mention that. With osteoarthritis, it's not autoimmune. It's just localized to those specific areas. So fatigue would be unusual. With rheumatoid arthritis, fatigue is often significant or severe, with onset 4 to 5 hours after waking up. It can also cause tenderness, which is very common in osteoarthritis at the affected joint. Rheumatoid arthritis also almost always has tenderness, and that's the most sensitive indicator for inflammation. Swelling, osteoarthritis may have effusion that's common. They don't really have much synovial reaction, and then they rarely have swelling. With rheumatoid arthritis, you'd have fusiform, soft tissue enlargement. Effusion is common as well, but you have synovial proliferation and thickening. It's often symmetric between joints, and you can also have characteristic rheumatoid nodules. There's not usually much heat or erythema with osteoarthritis, but there's a little bit with RA. And then there could be joint enlargement. You probably have seen that in these patients. In osteoarthritis, it's mild and it's usually firm in consistency. The joint enlargement would be more moderate to severe in a rheumatoid arthritis patient.
And also the location of the joints that are affected. So we already kind of mentioned with rheumatoid, it's the feet and hands. Obviously with osteo, we typically will see the hands as well, but we also kind of think knees and hips and some of the bigger joints. So that's, not that rheumatoid arthritis can't happen in the hips and knees, but it's just going to be more uncommon in those cases, especially in the hip. The closer you kind of get to the spinal cord, if you will, you're going to get less common, effects of rheumatoid, where we see it pretty commonly with osteo. So as far as, kind of assessing, the severity, and looking at, how we would kind of quantify the patient's, baseline and then their progress or worsening, improvement, and, kind of being able to follow that. There's a few different scoring systems that are available. So there's several assessment tools, and all of these can be potentially utilized. There's going to be some that are going to be used in certain clinical trials, and others that are used in others. But for example, we have like the clinical disease activity index, and we have the disease activity score, which is the DAS-28. We have the patient activity scale, or the PAS. The routine assessment of patient index data 3, or the rapid 3 is another way for that. But basically what they're getting at with these scales, and they all have different scales. Like, for example, the clinical disease activity index is 0 to 76 that you can score, whereas the disease activity score, the DAS-28 is only 0 to 9.4. So it's very different scoring systems. So you have to make sure you're looking at the scale that's appropriate. But you're looking for the breakdown of high disease activity, moderate disease, low disease, or remission. And that differentiation between low disease and remission, I think, is going to be kind of an important thing that we'll bring back up in regards to the new guidelines.
No, talk about that now.
Hey, sure.
Well, so one of the updates with the new guidelines,
trying to do another cliffhanger.
Well, we could have, but I didn't know if it would come.
Missed opportunity.
I didn't know if it'd come up naturally again.
Yeah, it came up so naturally.
We'd have to force it in,
Yeah. Okay.
Now
cool.
it's natural.
Keep going. Now it's very natural.
Now. And it's not awkward or anything. This is perfect.
Right. Yeah. Everyone's very
It's happening
very
at the
focused.
exact perfect time where we wouldn't have to go off track or anything. It would just happen right here.
Right. There you go.
Perfect.
Okay. Tell us.
Yes. So the updated guidelines mention a treat to target approach with treating these patients. Historically or traditionally, they say usually it would be more of a physician-patient conversation about how they felt like their disease was progressing or improving, and that would help determine whether they needed to escalate their therapy and that sort of thing. Treat to target is more referencing these severity indexes and using one of these evidence-based severity indexes to tell you for them to fill out or for you to score and to say exactly where they're at with that, and then tailor their treatment towards that accordingly to target a low disease activity and not necessarily remission like Mike mentioned, because that's not always possible. That can be discouraging to patients if it's not feasible. So targeting treat to target of a low disease activity based on one of these severity indexes.
And I think this made me think of like the when we were talking about opioids and like pain management. Like one of the things that you'll hear people kind of say when we're talking about pain management is, telling, like, kind of being realistic with expectations for a patient. Like patients shouldn't be under the impression that like I'm just not going to feel pain ever. Like, and being kind of, because if that's the goal, they're never going to get there, and they're just going to have to keep increasing therapy and whatnot. So being realistic, like, hey, we're going to make you as comfortable as we can. It's still not going to be perfect, but you have a disease, and we have to just do our best with it. But giving them realistic expectations, so you're not getting the discouragement, like you said.
Functional, but not necessarily pain-free, not necessarily cured. Right.
Yeah. I mean, I think that's one of the reasons why they like that targeted treat, because as people are getting older, you're going to have aches and pains, and just natural course of life.
It's all about setting expectations, which I think, like you said, is important with many disease states, because if you shoot for low severity and they achieve remission, yay.
People like a specific goal, like a number goal to reach. So
that's
achievable.
Where you're, just like with weight loss, right?
Yeah, just lose weight.
Yeah, lose weight.
We say that to patients all the time. It's like, lose weight or exercise.
Right.
Okay, and then what will that do? Like, after a certain point, do I just have a guy hand me a sack of money? Like that? But that's why, like, with like blood pressures, I've actually shown people with it getting low, because I think it gets that buy-in.
It does.
The why.
It's what you need.
You need it.
I'm always asking why. Probably to a very annoying extent at work, but
why we do it this way? That's stupid.
I question too much. Usually just to myself.
Dude, but the thing is, supervisors love that.
They love it when you question them.
Everything. And you go, why are you doing it that way? That seems pretty archaic, but okay, what do I know? Yeah. Just kidding, bosses that are listening.
Okay. So do you want to talk about treatment?
I guess we might as well talk about some treatment options.
Might as well do some drugs because we are a pharmacotherapy podcast.
We are.
All, so it might be beneficial.
DMARDs?
Yeah.
Kind of the whole podcast password for this episode?
It sure is without the S.
Not the S, yeah. DMARD.
DMARD.
Very important.
We had to
do not put
that.
the S. We did have to double check before we start recording.
Have we even said what that means?
Well, I'll tell you right now, Cole. It is disease-modifying anti-rheumatic drugs.
Or drug if you're doing the...
No, we're doing drugs because we're going to talk about multiple ones.
Just don't do that for the password.
Yeah. Exactly.
Yes.
Now they're going to get confused.
So the guidelines changed a little bit around... we'll get into that a little bit later. I'll give you a cliffhanger for that. But around the recommendation in certain disease severity with what to start or what not to start, patients with symptomatic RA should be started on a DMARD. So that's pretty much accepted. They have various mechanisms of action that can slow the disease process and help prevent further joint damage. Like we said, we would love to have remission, but ultimately shooting for low disease activity is probably a more realistic goal. The guidelines have kind of updated about bridging. So bridging is usually where you would start a low-dose steroid for a period of time while the DMARD takes effect. It can take a while, 6 weeks or however long. So you would use a steroid to bridge to help with the symptoms until the DMARD kicks in. The recommendation was generally to use the lowest effective dose for the shortest time possible, and then NSAIDs were not as effective. So the new guideline actually has it's not a strong level of recommendation, but it's a conditional recommendation to avoid using low-dose prednisone as a bridge. And they say because for the most part, patients in many cases will continue on it longer than you wanted them to.
Yeah.
And so
just stay on it.
If you're following it and you use the lowest effective dose for the shortest time possible, then that's still appropriate. It's just to make a blanket recommendation to do this for everybody. They just say that a lot of people end up on the low-dose steroids for a long time, and we all know what kind of issues can come from that over time.
I literally had a patient that this happened to on this past Wednesday, and where their rheumatologist left them on prednisone, just continued it. I guess the MA just kept refilling it.
Yeah.
Patient said, and then they ended up getting an injection in the joint as
Steroid
well.
Injection.
So now their A1C is like out of control,
all over the place.
Oops.
So I would take it. For me, I would take it patient to patient, and you also have to be aware of how your practice is as far as, are you going to make a hard line about after a certain period of time, no more refills on this, and whatever.
I definitely think it should have at least some kind of an idea of a stop date when it comes to steroids.
You just don't want to leave them on it in perpetuity.
Solid.
I'm sure I used that word correctly.
I feel like, and maybe. So I do think it's important to clarify, because DMARDs is a term that kind of is an umbrella term, if you will. There are sort of like subcategories of that term, and really when we classically think of DMARDs, we're thinking of what they would call like CS DMARDs, which is like conventional synthetic DMARDs, which is like our methotrexates and the drugs that we're about to talk about. Then we also have our biologic DMARDs, and then we have our targeted synthetic DMARDs, like the Xeljanz and things like that. So they are all technically DMARDs, but they are kind of subcategorized in that way as well. So I don't.
In all instances, they modify the disease activity and their anti-rheumatic drugs.
I feel like I'm very guilty of like using DMARDs only for methotrexate and then calling them biologics for the TNF alpha.
I feel like everybody does that.
Yeah.
Which, I mean, it gets the point across, but technically.
But then the students or whoever sees the algorithm on that thing, they're like, oh, wait a minute. Yeah. Yes. So that's what that is. So.
Yes. Not just a trivia fact.
Not just trivia.
It's to help.
It's to help, because that's what we do.
We serve.
Well,
we protect and serve.
We're like police officers, but just with a podcast. Okay, so methotrexate. Let's start there, because that is our golden ticket when it comes to our conventional DMARDs. We have a few others that we'll mention, but the guidelines are very specific about liking methotrexate, especially in the case of like moderate to severe rheumatoid arthritis. That's typically what we're starting off with. So mechanistically, it is a folate anti-metabolite that is inhibiting DNA synthesis, repair, cellular replication, and it's also inhibiting dihydrofolate reductase. And so folate supplementation does end up being a factor that we need to consider when we have a patient on long-term methotrexate. Dosing wise, this is another kind of thing the guidelines did specify. The dosing can be kind of in a range of 7.5 to 30 milligrams once weekly. It does come as a oral tablet, a sub-Q injection, or even an IM. Typically sub-Q is what you would see. The guidelines do want patients starting out on oral therapy, ideally over sub-Q, which is kind of backwards from the GI standpoint. So it's a little interesting. I guess because the oral being GI, you don't want that. So I guess that makes sense. I answered my own stupid question. Idiot.
What we do here, we answer our own
stupid questions that we ask. But the other thing is over the first 4 to 6 weeks, they want you to try your best, and I'm assuming the patient can tolerate, to get to at least 15 milligrams for the weekly dose in that first period of time. And so if it's taking longer than that, maybe assessing why the patient is having side effects, or what maybe the case by case situation is. Maybe increasing folate supplementation, things like that. But methotrexate is long-term can be known to cause hepatotoxicity, myelosuppression, mucocystitis, and so it's definitely not a benign drug. It's nowhere near as intense as far as the monitoring goes with the liver function and all that. I mean, they used to biopsy people after a certain amount of time for everybody, so it definitely relaxed a little bit. But it is still something that we need to consider. If you have a patient who's drinking heavily, or they have hepatitis C or B, or whatever else is going on, it would be something that you have to at least keep in mind. Right. It's also contraindicated for pregnancy. So if that's on your mind, and you have a patient who's thinking about pregnancy, we definitely got to go stay away from this one in particular. Adverse effects that are much more common than a lot of patients will deal with: the GI upset, so nausea, vomiting, diarrhea. It can cause an increase in LFTs, even if it doesn't lead to hepatotoxicity. There are cases where it can lead to alopecia and photosensitivity as well. So we want to at least check LFTs at baseline, and then for the first 3 months, we're checking a little bit more frequently, every 2 to 4 weeks or so. And then if we have a dose increase, then we're going to check more frequently and continue to check more frequently. Or if we've stabilized their dose, then it's going to every 8 to 12 weeks for 3 to 6 months, and then less frequently at the clinician's discretion. But do make sure that we're testing for Hep B and Hep C, as well as tuberculosis prior to starting.
Yes. And that's
just going to be a general theme.
Yeah, for all these, really. And it's important in this instance, because Mike mentioned the biopsies. You don't liver biopsy everybody, only in certain situations at your discretion. Maybe, like Mike said, history of excessive alcohol use, ongoing Hep B or Hep C infection, or recurrent elevation in the liver enzymes. Specifically
aspartate aminotransferase.
Yes, specifically aspartate aminotransferase. It's folate, so it's a folate antimetabolite. So folate can be given to decrease certain issues, hematologic, GI, hepatic adverse effects. It's usually given either 2 different ways. 5 milligrams once a week on the day after they take the methotrexate. Remember that's once weekly as well. Or you give 1 milligram once a day on days you don't take methotrexate, so 6 days a week. The 1 milligram tablets are only available as prescription.
Yes. So don't tell them to get it over the counter, because I think it's 0.4, and then 0.8 if it's prenatal.
Prenatal is 0.8,
but just standalone, I think. So make sure they get in the right, the right dose.
2.5,
which is a pain. Just give them a
prescription. Just a pain, and you got to know those things are tiny. How you split those things?
Just pill cutter, probably. I would imagine. if I had to,
I was going to use my canines. Teeth, not my dogs. My teeth.
That's good. Yeah, I feel like that would get gross really quick. These pills are dissolving via the canine saliva.
I was trying to think of what the tooth beside the front tooth was. What is that?
I don't know.
An incisor?
Maybe. That sounds right.
I think that's it.
I think it is.
It just came to me.
You're like a dentist.
Might as well
You're like a dentist, basically.
Basically a dentist.
Tell everyone, Cole's a dentist now. So, that's our main DMARD. That's a conventional DMARD. That's going to be utilized more so than the other ones we're about to talk about, but we'll still touch on these other ones because you will still see them in patients. So Lipflunamide is another conventional DMARD that it basically works by inhibiting pyrimidine synthesis, resulting in anti-proliferative and anti-inflammatory effects. It has a box warning for embryo-fetal toxicity as well as hepatotoxicity as well. If a female patient is going to start this, they must have a negative pregnancy test prior, as well as ensure that they're using 2 forms of contraception during treatment. The issue is if pregnancy is desired, technically speaking, we are supposed to wait 2 years after discontinuing this medication.
That's wild.
Unless we can get undetectable levels reached. Or we do have another method where we can use accelerated drug elimination procedure.
Sure.
Sorry, the dogs are barking, guys. They're part of the podcast.
Your feet are hurting?
No. I said, sorry, the dogs are barking.
Your feet are hurting?
My feet are fine.
Okay.
I don't know what my feet have to do with this.
It's a southern colloquialism.
Is it?
My dogs are barking.
Oh,
it's from a movie from a long time ago.
I don't like that.
The 50s.
You're just playing into the stereotype of the southern people. We don't talk like that. We're smart. And
everyone else from around the country is like, y'all have really bad accents. I just said y'all. See, I mean, we
say y'all. That's fine.
We do.
Is it from the north and say pop instead of soda?
I'll tell you what.
Get out of here with that. I have a couple students that keep saying that. I'm like, stop saying pop. It's driving me crazy.
I know. Well, neither of us are southern enough to call it Coke. To call everything Coke, are we?
I just say soda.
I say soda too.
Yeah.
But the real Southern people just call
anything Coke. I don't care what the brand is.
Any
Coke.
carbonated beverage would be a Coke.
Yeah. Well, you know what they say.
Yes.
What
do they say?
I don't know. Some stuff. Okay, so back to Lipflunamide. So LFTs also need to be checked and monitored, monthly for the first 6 months, and then we can kind of relax a little bit after that. Also, some serious skin infections, including Stevens-Johnson's, not infection, I'm sorry, reaction is what I meant to say. No, I don't want you guys to get confused with that. So Stevens-Johnson's can also lead to peripheral neuropathy and can also elevate blood pressure as well. So a lot of different things we need to keep in mind. Can also increase the risk of respiratory infections, GI effects, rashes, headaches, yada, yada, yada. It goes on and on. So. And if you want a ton of side effects, this is the drug for you.
There's plenty of side effects associated, especially with that pregnancy thing. But if you needed to do the accelerated drug elimination,
we have an option.
We have a couple options. Cholestyramine, 8 grams, 3 times a day for 11 days, or activated charcoal suspension, 50 milligrams every 12 hours for 11 days.
Activated charcoal suspension. You basically have to pretend that you've given yourself an overdose. Or just this drug maybe, and
many drugs, I guess.
Any drug, and then you just give you activated charcoal. And you're like, I'm self-treating my toxicity.
I just can't believe it hangs out for 2 years.
It's crazy. Cholestyramine would be my choice because it looks like orange juice, looks tasty.
I don't know. It always sounds.
I've never tasted it. It's probably disgusting.
Well, they have multiple flavors now.
Do they?
Yeah, because I had a guy who did not do the orange, and turns out there's 4 other flavors.
What? I've only seen orange.
I'm pretty positive I recall this. It was multiple years ago. But I had to special order this.
That's like a 50-50 chance that that's accurate.
I had to special order this certain flavor for him. And then we would accidentally, of course, occasionally somebody filling in would dispense the orange. And then he'd bring it back. And I'd have to special order the cherry or whatever it was. I can't remember. I think it was a clear. I think there is a...
Clear?
I think there is a... flavorless. I'm making stuff up.
We do a lot of thinking and more so just kind of pondering in this podcast.
Somebody knows that there are different flavors.
Yeah, I feel like you could just use a lot of Crystal Light or Mio and just really overpower the flavor if you needed to.
Well,
versus
this dude did not do the orange.
He was not about the orange.
I would say sorry, buddy, except somehow he knew that there were other flavors out there, so he had me special order them.
Yeah. No, and he's bringing it back. Could you imagine bringing the? I can't do orange.
Oh yeah,
hate it.
Well, we were a customer service oriented pharmacy, so
I would have been like,
hey, what we needed to do.
This is what I said. I would have been like, you're an adult man, right? Here you go. Here's your orange. I'm just kidding. I wouldn't have said that, folks.
So the next CSD-MARD is sulfazalazine. It's a prodrug. It's cleaved by bacteria in the colon into sulfapyridine and 5-aminosalicylic acid. We think the sulfapyridine moiety is responsible for its anti-rheumatic properties, though the exact mechanism isn't known. But because of that sulfa moiety, it does have some contraindications. A anaphylactic sulfa allergy would be one, or a salicylate allergy because it has 5-aminosalicylic acid in it. Also, a GI or GU obstruction would be contraindications. Be aware that this can also cause Stevens-Johnson syndrome, severely affect the liver, cause hepatic failure in certain instances, as well as pulmonary fibrosis. More common adverse effects: headache, possible rash, anorexia, dyspepsia, nausea, vomiting, diarrhea, and folate deficiency. You want to monitor CBC, monitor LFTs at baseline, and then every other week for 3 months, monthly for 3 months, and then once every 3 months. And this is another of those drugs. I feel like we talk about one every episode now, that can discolor the skin or urine yellow, orange. Did we bring this up last time?
Because we talked about ulcerative colitis. We brought it up.
We brought it up. Yeah.
Yeah.
So yellow, orange coloration of the skin or urine.
Yeah. And last but not least are probably least effective conventional DMARD.
Least effective, but...
So last and least.
But least side effects. Yeah, least side effects. Not side effect free, of course,
except,
but least side effects.
Unless you're really worried about your eyesight.
Yeah. So, unless you want to see.
Yeah, if you want to see, this might not be.
Do you like being able to see?
Yeah. If you could take it or leave it, then this
Though,
is
at the same time, well, we'll get to it. But the monitoring, to me, is lacks for the concern.
That is true.
You know what I'm saying?
Yeah.
Just once every 5 years. It's like, whoop, okay. I thought it was a little more important than that.
What if I lose my eyesight at 4.5 years?
I know.
That's going to be so ridiculous.
I know.
Hydroxychloroquine. So you guys are like, what the heck drug are they talking about? Hydroxychloroquine is where we're getting at. You guys probably all remember this because that was like one of the first things they all thought was going to cure COVID. And then it was just like a mad rush on hydroxychloroquine. Let's all stockpile it. And that way, everyone with rheumatoid arthritis was like, I
remember we were having to limit quantities that we were dispensing. And if it wasn't for something like this, then like we could only dispense a certain amount. It was, man, I forget about all that stuff.
Feels like a long time ago now.
I'm trying to black it out of my memory.
But this is basically inhibiting the locomotion of neutrophils and the chemotaxis of its eosinophils. So it also impairs the complement-dependent antigen-antibody reactions. So some warnings to kind of be aware of, like we already mentioned as far as the eyesight goes, the retinopathy, and as well as macular pigment changes. And then it can also lead to neuromuscular weakness, cardiomyopathy, bone marrow suppression. So, for example, anemia, leukopenia, thrombocytopenia. And so some pretty serious adverse effects, which is why we just didn't want people taking it like crazy until we knew that it actually was effective. Adverse effects that are very common would be the GI effects, abdominal pain, rash, pigmentation changes of the skin and hair. That one's a little bit more rare, but the GI stuff and skin stuff definitely. So monitoring the CBCs as well as the LFTs at baseline, and then kind of periodically. You don't have to be as rigorous in testing as you do with the others. But the retinal damage that could potentially occur can, in some cases, be irreversible. So that's kind of like one of those things where what Cole was talking about. It seems a little bit like a scary side effect that we don't actually monitor for that closely. But for patients with risk factors for developing retinal damage, so like low body weight, if they have some sort of renal or hepatic impairment, those patients need ophthalmological exams annually while they're on treatment. If patients don't have those risk factors and you're like, nah, it'd probably be fine, ophthalmic examination should be completed within the first 5 years of starting hydroxychloroquine and then repeated annually. So then they get a little bit more.
Oh, they do repeat annually?
Yeah, they do repeat annually, okay. But still, that first 5, I guess I would probably be like, okay, how about 2 years and I'll just get it. I'd get ahead and get it started. 5 years. I'd get my eyes
5 years, and then why is it annually after 5 years?
I would imagine because the data shows it happens at like year 7.
I suppose.
I'm very logical, Cole. You got to learn that about
Mike
me.
Mike is a logic-oriented man.
Always.
He always goes logic. Whenever he says, should I spend money on this, he only uses logic to decide.
I say yes, because it's the podcast, and we got to give the people what they want.
Should I spend money on this grass?
Thing that I don't need.
The answer is yes. I should spend money on this grass. Okay, yes. So it's often used, if it's used in mild RA, can be used by itself or as an adjuvant in combination DMARD therapy in more progressive disease. This, just like the others, can take a while to start working. It can be delayed up to 6 weeks. It's only considered a therapeutic failure if it's been 6 months of therapy without a response. And kind of like we mentioned, the main advantage, even though it has its risks, is the lack of myelosuppressive effects, hepatic issues, renal toxicities that are associated with the other DMARDs.
And we'll kind of like summarize all this data as far as where the therapy goes. But we typically save this for like very mild cases, like you were saying, Cole. So, you're not going to see this too often unless the patient's like, kind of just having issues.
I mean, we had a fair amount of people on it, but
or at least according to the guidelines.
Right. We had more people on methotrexate. There's just a lot of people have rheumatoid arthritis.
Yeah,
or rheumatoid issues.
There you go. So let's get into some of our newer DMARDs, our biologic DMARDs. Now, we've just talked about these recently because we did Crohn's and ulcerative colitis, some other things that we talked about, TNF-alpha, biologics. And luckily, the drugs are basically the same.
Stuff.
They're the same ones.
A lot of crossover.
So Humira is a big one that is utilized. It's one I know like at our clinic that we use all the time.
It's relatively older compared to the others, too.
Plus, we have the 340B pricing, so we get Humira real cheap.
Yep.
So that's fantastic for our patients because otherwise they would just be stuck with something they couldn't keep, you couldn't afford, or it would just be on the much less effective medication. But as far as Humira goes, we've talked about this a lot on the podcast, but we're basically administering subcutaneous injection every 14 days, and usually do a loading dose, and then you start your every 14 days, a week after that loading dose. It kind of changes a little bit depending on whether it's psoriasis or whatnot, but definitely double check your Lexicomp or your Pearls or one of those apps. See what I did there? Pearls.
Nice.
Sponsored the podcast. Shout out to Pearls. Thank you guys so much. I lump them with Lexicomp because they're an up-and-comer. I love them. So if you haven't checked out Pearls, by the way, www.pearls, that's pyrls.com/coreconsultrx. They just posted new asthma 2022 treatment algorithms as well as smoking cessation that are awesome looking. Check those out. You're gonna want to get your hands on a copy. So sign up today. Thanks, Pearls, for sponsoring. As always, appreciate you guys. Okay, so Humira does have several biosimilars that are available now. So make sure that the patient, insurance is, doesn't have one in particular they'll cover and not others. Kind of like we're seeing issues with insulin billing and stuff now. That we don't want a patient to not be able to get the medication just because of insurance issues.
Stupid insurance issues.
Yeah. We do have to worry about some local injection site reactions. That's going to be the most common adverse effect. However, the citrate-free formulation that they have now is definitely eased up on some of that. So that's helped quite a bit, but it's still a possibility, obviously, with any injection.
Yep. So the next we have is Ambrel. It's another anti-TNF biologic. The generic is etanercept. So it's 50 milligrams. It's also a sub-Q injection once a week. Localized injection site reactions are common, but otherwise it's reasonably well tolerated. Rarely it can cause neurologic demyelinating syndromes, so that would be like a multiple sclerosis. They have been associated with the use of it, but that is rare. Per the trials, it seems to slow disease progression to a greater degree than oral methotrexate. Still, oral methotrexate is recommended first line. And it does have a biosimilar branded as Erelzi. They are not interchangeable per the Purple Book. FDA Purple Book.
Purple Book
yes.
Tells you that biosimilars can be interchanged.
Yes.
Fun facts. This episode has so many fun facts. Infliximab Remicade. This is the IV infusion TNF-alpha, and this is one that is given every 8 weeks, so you get a little bit longer, in between your infusions, but you do have to give infusions. So the concern with the IV infusion is that it can cause the formation of antibodies in response to, basically a foreign protein being administered. So, one of the recommendations can be oral methotrexate, given kind of concurrently for as long as the patient continues the infliximab. That somewhat conflicts a little bit with the guidelines because they do kind of tend to think more along the lines of monotherapy. I would say that this would, in this particular case, maybe be a better case for this particular TNF-alpha inhibitor just because of that antibody potential.
And I guess the guideline recommendation is more to start with monotherapy with methotrexate. But if you end up moving to this, you would still want to do methotrexate along with it.
Yeah. There you go.
And you can still go to combo methotrexate biologic as a next step. Yeah. Either way.
So the loss of response, though, is even if you've had an initial a good initial response, they may try increased doses or shorter intervals between doses to kind of maintain that response. But some patients may lose the effectiveness of the drug because of those antibodies that form. Acute infusion reactions can happen as well, and so the treatment can include slowing the infusion rate itself. Also, in some cases, they'll administer Tylenol, diphenhydramine, maybe corticosteroids. I would say that would be a big if, depending on the clinic protocol. But if the patient does develop those infusion reactions, then that's when you might want to actually pull out the corticosteroids. But pre-treating, it just kind of depends on the clinic and how what their protocol is.
Right. So that's Infliximab. Mm-hmm. We have a couple others. Simponi, generic is Golimumab. It's also a sub-Q injection, 50 milligrams once a month. There's an IV injection as well, Simponi Aria. It's 2 milligrams per kilogram infused over 30 minutes, and that happens at week 0, 4, and then it's just every 8 weeks after that. There's also Cimzia, Certolizumab Pegol. It's a sub-Q injection, 400 milligrams at weeks 0, 2, and 4, and then 200 milligrams every other week. It does have an alternative dosing schedule of 400 milligrams every 4 weeks as well.
It seems like a no-brainer.
Does to me.
Going to go every 4 weeks.
Unless I'd imagine it's a larger amount, so it might just cause more injection, side reactions, side effects. Yeah.
Now look who's thinking logical now.
Cole's logical now. We're just two logical guys.
You're like a pharmacist, dude. If I were to put a title on it.
If you had to guess what I was going to do with my life.
Business guy.
Yeah.
Newspaper editor.
Yeah. Not PharmD.
Oh, could you imagine? I would quit in 3 seconds. So when we think of the class of TNF-alpha inhibitors altogether, the box warning that's associated with the class is because they do increase the risk of developing serious infections, some of which could be fatal especially if left untreated. But demyelinating disease, like Cole had mentioned, seizures, hepatitis B reactivation, even worsening heart failure, especially if patients who are already symptomatic with heart failure. There's cases of hepatotoxicity, and it's just one of those things that we do have a lot of concerns with. So they are very effective, but we want to maximize the patient's kind of trial of methotrexate that's a little bit more safety, a better safety profile before jumping to one of these. Plus the price also doesn't help either.
Right.
But you do want to start, before starting any of these TNF-alpha inhibitors, make sure you get a TB test, as well as do an assessment for hepatitis B and C, get a CBC, LFTs at baseline, make sure all that stuff is documented before starting treatment, because you definitely don't want to miss a patient that has even kind of suppressed Hep B or Hep C. And we actually had a patient who just started on Humira, but we started him on Epclusa for Hep C at the same time, and we waited on the Humira so that we could get the Epclusa going, just so that we don't worsen that.
Nice.
Because it can basically increase the viral replication. Mm-hmm. So it's like, oh no, we're churning them out now. That's what we said.
That was the
you feel like you're
technical term.
Yeah, that's what we said on rounds, basically, or in the office we were sitting in.
Yeah,
not really rounds. I say rounds just to make it sound like we're cool. So let's talk about some of the non-TNF-alpha biologics.
So non-TNF.
Miscellaneous biologics.
Miscellaneous.
We should call them that.
They're still biologics. They're still DMARDs.
But they're non-TNF-alpha.
But they don't act on TNF-alpha.
So and they're also not targeted. I guess they'd be targeted. That's a better name for it. Targeted synthetic biologics. Yeah, because these are very
don't
specific.
act on TNF-alpha.
Right, but not that target.
Different targets.
Very confusing.
So what do they target? So we have one, Orencia, a beta-sept. So it inhibits T-cell activation. It binds to the CD80 and CD86 on antigen-presenting cells. That probably sounds pretty familiar as far as the mechanism of action. Blocking the required CD28 interaction between the antigen-presenting cell and the T cell. So where is it used? In patients who failed to achieve adequate responses to the TNF-alpha inhibitor. One half had a clinical response to a beta-sept, for reference. So there's a trial called the Ambrel trial. It was a head-to-head trial. A beta-sept added to a stable methotrexate dose showed similar efficacy and adverse effects to Humira plus methotrexate in biologic naive patients with an inadequate response to methotrexate monotherapy. So they didn't do well on methotrexate monotherapy, and so this was similar to Humira plus methotrexate. So this added to methotrexate was similar. It does have a variety of adverse effects: headache, nasopharyngitis, dizziness, cough, back pain, increases in blood pressure, dyspepsia, UTI, rash, and extremity pain. So a fair amount of things.
A lot of things. We also have Rituximab, which is a med that depletes CD20 B cells, and that's kind of how it's thought to play a role in RA development and progression. This is actually, again, kind of been shown to be useful in patients who have failed methotrexate or a TNF-alpha inhibitor, and it's given as 2 infusions, 1,000 milligrams, 2 weeks apart. They also will oftentimes give methylprednisolone 30 minutes prior to the rituximab to reduce the incidence and severity of the infusion reaction that can occur. And then methotrexate should be given concurrently in the usual doses for RA, as the combination has proved to kind of provide that best therapeutic outcome in this case as well. And the duration of benefit definitely is variable, depending on the patient, but it's not unlikely that the patient won't need another treatment if they have reactivation of the disease.
Yep.
So,
last one in this classification is Actimra Tosylisumab. It blocks interleukin receptors, specifically IL-6 receptors, and that's going to prevent the cytokine from interacting with them. It's used in moderate to severe rheumatoid arthritis in patients who have failed 1 or more DMARDs. There was a trial called the ADACTA trial. Patients with severe RA unable to use methotrexate found monotherapy with Actimra more effective in symptom improvement than Humira monotherapy. So I guess that's a positive thing. I don't really. I mean, I see this. I've seen it used, but I don't know that it's used ahead of Humira.
Yeah,
not that I'm aware of.
I feel like most insurance, because technically speaking, you could go either the TNF-alpha route or the other targeted therapies. But I feel like most of the insurance companies want to see TNF-alpha first.
I think so.
It ends up becoming like a prior auth issue.
Yeah.
So they kind of force their hand,
right,
as they do. All right, so our other class, and I think just for time's sake, we probably could lump these in together. I'm also not a huge fan of these either, but
not as important.
The Janus kinase inhibitors. So Xeljanz was the first one to kind of hit the block, and just like it says, it inhibits that specific enzyme, the Janus kinase enzymes, which is going to kind of stimulate that immune cell function. They've had several box warnings, including serious infection risk, tuberculosis, fungal, viral, bacterial, and then even potentially increased risk of lymphomas. One thing that's been added recently, and this is actually because of the rheumatoid, its use in rheumatoid conditions, but major adverse cardiovascular events has also been added, especially in patients who are 50 years of age or older with one cardiovascular risk factor. Their risk of having an event, a major event, so an MI, stroke, what have you, compared to TNF-alpha inhibitors was significantly higher, and especially in patients who were current or past smokers, were even higher risk. So this is something that they are monitoring, but there's even now talk that it could potentially, this is based on post-marketing safety data, but there's some data now that shows that it could increase mortality risk too. So lots of stuff that the FDA is kind of keeping their eye on. There are 5, sort of box warnings that are separated out for this class of medication. Definitely one that we need to kind of keep an eye on and monitor over time. Obviously not we. I say that I lump myself in with the FDA, obviously, but it will be as clinicians being watched to make sure that we're not just putting anybody on these, and if they have some of these risk factors, we got to be real careful.
Right. So so they're not used as often, but you will see them, and so that's why you want to be aware of those things. Just to kind of finish them up, there are a couple more. Xeljanz is probably the most common one you've heard of. There's also Olumiant, baricitinib. It was approved in 2018. There is also Rinvoq. I feel like I see this maybe just because it's newer. This one pops up a fair amount. Upadacitinib. It was approved in 2019. It's a capsule you take once a day. There was a trial called the Select Beyond trial, which was Rinvoq plus methotrexate versus Humira plus methotrexate. And the Rinvoq group was superior in terms of improving signs and symptoms and physical function, but had higher rates of herpes zoster and creatinine phosphokinase elevations. And then, of course, it has the concerns related to JAK inhibitors that we have. Yeah. There are some stipulations about starting them. Do not start if the absolute lymphocyte count is less than 500, hemoglobin is less than 8, ANC is less than 1,000. Mike mentioned various things we're concerned about: increased risk of malignancy, increased risk of thrombosis, and Mike mentioned the possible increased risk in mortality. So, yeah.
So let's summarize all this, Cole.
Let's do it.
So one of the things that is kind of, I guess, been around for a while was the concept of like double and triple therapy, specifically triple therapy with methotrexate, sulfasalazine, and hydroxychloroquine. So basically much cheaper combo therapy that you can give versus one of the very expensive biologics. So they did a study that compared that triple therapy with or versus Ambrel plus methotrexate, and in that study there was a non-inferior clinical benefit. There's also another study that looked at the methotrexate, sulfasalazine, hydroxychloroquine versus Infliximab plus methotrexate. Now, in that study, Infliximab methotrexate did have more benefit as far as clinical outcomes, but the 12-month mark, but that had been that was washed away by the 24-month follow-up. And so it's kind of hard to tell whether that was from antibody formation from the infliximab or what, but the guidelines still kind of do push maximizing the use of methotrexate monotherapy before going this route, just because you're compounding the risk of those side effects, and even the ones that have specific unique side effect profiles like the retinopathy with the hydroxychloroquine, you're just adding that to the list of other potential toxicities with the other agents. So you got to be careful with that. In some cases, if the patient only has certain options available, maybe you do have to go that route, but make sure that you've maximized that methotrexate monotherapy first before starting to switch things around.
Yeah. And if you do need to switch things around, there's the various combination therapies like you mentioned. Addition of a biologic DMARD with methotrexate if possible. You'd probably go TNF alpha inhibitor, then a non-TNF alpha biologic, and then you might consider Xeljanz if you had to.
And the guidelines do specifically mention Xeljanz, because I don't think the other ones were too new for them to include.
Yeah, I mean, they were both there, but I guess
they just didn't really mention them.
Right.
They do give some specific situations. So, for example, if they say if a patient has moderate to high disease activity, we're trying to push them to low activity. And let's say that they still have that moderate to high disease activity despite being on a single TNF alpha inhibitor, so monotherapy with Humira, let's say. They recommend either adding methotrexate to that if they're not currently on a DMARD, like a conventional DMARD. And then if you do consider switching them, they want you to switch to a non-TNF alpha biologic over switching to another TNF alpha inhibitor in the same class. Basically in the same class. They do prefer the non-TNF alpha biologic, and they also prefer that over Xeljanz as well. So kind of like Cole said, they save that for after you've tried some of the other classes. Another example situation that they give is if patients have moderate to high disease activity despite 2 or more sequential TNF alpha inhibitors. At that point, they're like, okay, we really need to cut our losses, non-TNF biologic, and they say to do that over switching to Xeljanz or yet another TNF alpha inhibitor. Hopefully, by that point, you get the hint.
Right.
But some of the other cases where we use those TNF alpha inhibitors, sometimes they encourage you to try one. If one doesn't work, try the other. But this is, they kind of want you to change it up at this point.
Kind of separately, if you did one or more TNF inhibitor and then one or more, or at least one non-TNF biologic, then they would want you to try a different non-TNF biologic over using Xeljanz.
Yeah.
And they would really only want you to consider Xeljanz after a second non-TNF biologic.
Yeah.
It's a pretty last line.
Yeah.
If you get a patient to remission, don't discontinue their RA therapies. It's reasonable to consider de-escalating, but you would want to taper the therapy and pause or adjust based on recurrent symptoms.
Yep. There's also, if you check out the guidelines, we probably don't have time to go through it now, but there's also several comorbidities that they list, including, latent or active TB, pregnant or breastfeeding, patients with heart failure, certain melanomas, lymphoproliferative disorders, Hep C, Hep B infections, previous serious infections, and they give very specific guidance on which agents to choose and which comorbidity. So if you haven't done that, definitely check out the American College of Rheumatology guidelines from 2021, and they have it all listed for your learning pleasure.
It's all there.
Yes, it is. Guaranteed, or, well, you're not paying anything for this, so your money back. Anything else, Cole?
I think we covered it all.
Think we're about out of time.
We're
getting
up to
close.
date. Everybody's up to date now.
Yep.
But this is not up to date.
Yeah, we need a new guideline.
I know.
To include all the drugs.
We'll need...
There's a lot of things in the pipeline, too.
4 more years before they'll update it again.
We'll just update it for them.
We could.
Think they'd accept. Like, who are you idiots?
They pay us?
That'd be awesome.
Think those guys do that for free? I'm sure they don't, right?
No. There's no way. You think you'd write that guideline would take so long to write.
What kind of cash they make?
I would say they're pretty high-level guys. I feel like they're making some bank.
I would think so.
I feel like they're driving nice cars to the office every day. So. But anyways, make sure you guys, again, once you've listened to the podcast, kind of mull it over, obviously, ponder what you think about what we said. Go take that post-activity test. And if you're like, well, I can't take it because I'm not a free CE member, what are you doing? Go become a member. Let's get it going. They're supporting us. They've kept partnering with us. Definitely, check them out. They are very good website. I've personally used them for years, even before they ever approached me. So it's kind of cool to be working with them now. But check out their websites. They got a lot of good content on there. Again, there's a discount code in the show notes, so make sure you snag that if you're thinking about getting a membership. If you have any comments, questions, gripes, you want to reach Cole or myself, you can reach us in the show notes. The emails will be there, or you can reach us on any of the social media platforms. Do our best to respond. Thank you again to Pearls, as always. He's been a fantastic support to the podcast. And if you want more like traditional lecture style content, then check out the Patreon account. We have lots and lots and lots of lectures on there, all various disease states, and stuff's getting posted all the time. But it's www.patreon.com/coreconsultrx, and hundreds of PowerPoint slides on there. You'll have a whole library instantly. You could teach a class basically without doing any work. So I wouldn't recommend that. I think you should probably learn it, but there you go. We will see you guys in the next one. Thank you so much.